Good evening. Welcome to the San Mateo County Dental Society Member Symposium, where members have the opportunity to showcase their knowledge and skills. My name is Nesmard Morales. I'm a member of the SMCDS Leadership Council. Before we get started, I want to review how we will be running this meeting. All participants will be placed on mute. Tonight's presenter will provide information about the social determinants of health, diabetes, and oral health. What is the connection? Tonight's presenter is Dr. Kim Lucas Benton. Dr. Benton was raised in San Francisco, California. She is a general dentist in private practice in Daly City, California. She is a graduate of Meharry Medical College, School of Dentistry, class of 1988. Initially, following graduation from Meharry, Dr. Benton joined her father, Dr. Henry Lucas, in his private practice. And in 1998, after gaining considerable experience, she decided it was time to venture out on her own. In 1994, Dr. Benton joined the faculty at the University of Pacific Arthur A. Degoni School of Dentistry. She began her career as a part-time clinical instructor in the Department of Oral Diagnosis and Treatment Planning at the invitation of Dr. Peter Jacobson. Dr. Benton received her master's in public health in June 2018 from Capella University. Her focus is to create the awareness of the important connection between diabetes and oral health in dental clinical settings and within our communities. She has done extensive research over the past 4 years and has come to realize that there's a huge disconnect with oral health and the systemic connection. Please welcome Dr. Benton.
Thank you, Ness. I so appreciate being here tonight and appreciate all of you taking your time out. I know it's been a busy week, and hopefully I can share some pearls with you. I'm sure some of this you guys are already very familiar with, because we as dentists already know there is a connection with oral health and systemic health. So that being said, I am going to go ahead and share my screen. As Ness mentioned in the beginning, yes, we'll do questions and answers at the end. However, if we were in person, I would love to hold an interactive conversation with you. So you may hear me ask you some questions, and feel free to respond, and Ness can go ahead and read those questions to me or the responses. Okay, so here we go. Go ahead and put us in presentation mode. Here we go. So, diabetes and periodontal disease. What is the connection? So I want to start out by introducing my family. This is my wife, my wonderful husband I've been married to. We just celebrated 36 years of marriage. We met in college all the way on the East Coast at Howard University. He knew my goals, that my plan was to go to dental school and come back to California to practice with my dad. And he was very, very supportive. So we've been back out here since 1988. That's my oldest, that's my son, Mark. He was actually born 5 weeks before graduation, but you know, we do what we gotta do. And that's my beautiful daughter, Kayla. Both of my kids, I still call them my kids, even though they're grown. They are officers in the Army. They went through the ROTC program, which paid for them to go to school. Very, very proud of them. Our daughter, Kayla, is a nurse, just got back from Afghanistan, and she's in Colorado Springs right now. Our son, Mark, served 6 years active duty in the Medical Service Corps and then got called into ministry. So he's actually a chaplain candidate in the Army Reserve. So this is my why. This is why I get up every morning. So let's start with the obvious. Oral health impacts total health and well-being, okay? There's no doubt about that. Again, it's something that most of us know and or learning. And as Ness mentioned, I am on faculty at Pacific Degoni part-time. I'm there on Mondays. And now I'm in the Department of Diagnostic Sciences, and we teach the first-year dental students. It's called ICS, Integrated Clinical Strand. And we're teaching them not just the dental and oral health piece, but the biological, the microbiology, all of that, how it goes together. So they're learning this terminology as well, that oral health equals overall health. And as we know, your oral health impacts your ability to smile, how you speak, how you taste things, chew, swallow, of course, making facial expressions and how we show our emotions and feelings, right? It impacts our confidence. It also impacts our mental health. Some of us have seen people or patients come in, they literally have their hand in front of their face because they're embarrassed about their smile. It also impacts our job stability and security. And while hopefully people aren't being told, oh my gosh, you got to go fix your teeth before you can work here, people who have issues with their mouth, with their teeth, with their oral health, they know it, and it impacts their confidence in going ahead and securing that job or maintaining that job. So when we talk about overall health, not only are we talking about physical, absolutely we want to include emotional and mental as well. This is Dr. David Satcher. I'm sure most of you are familiar with him. He was the first Surgeon General back in 2000 to acknowledge that oral health is integral to systemic health. And if you look at the summary of the Oral Health Surgeon General's report back in the year 2000, you'll see it's very extensive. It's over 70 pages long, but the summary is amazing. And thank goodness for him because he brought it to the forefront. Just an aside, Dr. David Satcher was actually president of Meharry while I was there. Wonderful human being, always just caring for others. And it was just such a thrill to follow his career when he was the Surgeon General. So thanks to him, now everybody else is realizing, everyone else in healthcare is realizing the connection. If you don't have good oral health or ideal oral health, your general health can never be on point. Okay, that is a fact. And again, just want to thank him for pointing that out. So he was the Surgeon General back in the year 2000, and that's when this report came out. These were some of his key points. So the report was released in May of 2000, and it was definitely highlighting the bi-directional interaction between oral and systemic health. So not only do we talk about diabetes, we'll see later on in the presentation that we have other systemic issues such as heart disease, stroke, rheumatoid arthritis. There's a little bit on the fence about the premature birth weights, but the newest one that some of you have probably heard about is Alzheimer's. So there's a huge connection there. And of course, he talked about systemic conditions with oral manifestations, including diabetes. This is straight out of the report. He also said that oral disease can exacerbate certain systemic conditions, such as diabetes, okay? And of course, there's additional research that's needed to evaluate the pathogenesis and the therapeutic interventions, but you'll hear as I go on, the research is showing that there is definitely a connection. When we treat the pathogens in the mouth, it definitely helps to regulate the blood sugar, therefore affecting diabetes. And then the last highlight is findings suggest that the dental and medical profession will develop even closer linkages in the future. And this is where I challenge all of you. There's so many of our medical professionals, our primary care, our nurse practitioners, almost most people in the healthcare field still don't quite understand the connection. My goal would be that one day when we go see our primary care, after they weighed us and ask us about our exercise, et cetera, that the next question before they go over everything is, when's the last time you've been to the dentist? That's the goal. And the only way that's going to happen is all of us understand this and make that connection with our healthcare professionals outside of dentistry. Maybe it's your chiropractor, maybe it's your podiatrist, maybe it's your acupuncturist, whoever you know in the healthcare field, that we start sharing this message and asking them in turn to share that message. I've actually had patients here, physical therapists, nurses, MDs, and I will say to them, could you do me a favor? Next time you screen or have a consultation with one of your patients, can you ask them when's the last time they went to the dentist? And they are very appreciative and say, absolutely. They sometimes just need to be reminded. So I want to encourage and challenge each of us as you start seeing your patients, as you see your own primary care providers, to bring this up, that the connection is so important and that there are methods and insurance plans and things available to help people seek dental care. So here's where he talks about this. This is a highlight. Again, this is part of the Surgeon General's report. And you'll see here it says it was released again May 25th of 2000. And this is where he talks about it. Oral disease can exacerbate certain systemic conditions such as diabetes. You see the other ones here as well: respiratory disease, vascular disease, preterm low birth weight. I have a cousin who had their niece go into premature labor, and we knew that she was completely healthy, but we found out later that she had full-blown periodontal disease that was untreated. So while there's still a little bit out there on whether that's true or not, we are hearing and people sharing their stories about that. But I just wanted to point out again about the connection with systemic conditions and oral disease, as Dr. Satcher mentioned here in his report. And this is what we talked about earlier. Periodontitis can be linked to several systemic conditions. I'm sure most of you have seen this chart. There's other ones available, but they all pretty much say the same thing, right? Periodontal disease can affect your general health. We want to take that time to explain it to our patients. That's what I'm finding. It's amazing how when our patients come in for their, I'm just coming in for a cleaning, that's the time, of course, our staff and our back office team to explain what's going on, and our wonderful hygiene team. We as the provider and the practitioner, we have to come back as the dentist when we're coming in to do that examination, to back up our hygiene team and train our dental assistants to also talk about these things while they're waiting for us, right? Sometimes they just get a little distracted and they might be twiddling their thumbs, but they can have authentic conversations about just their overall health. So as you see here, it talks about respiratory infections. It talks about severe osteopenia, stroke, heart disease, uncontrolled diabetes. That's very important that we put that in there, uncontrolled diabetes. And the newest one is Alzheimer's. We'll talk about that in a little bit. So I'm not sharing anything new, but I just want to go over some of the basics. Periodontitis is a chronic inflammatory disease. You'll see in this photo on the left, the normal tooth structure. We all know about the healthy bone level, the enamel, the healthy gums, right? And then on the right, we can see as plaque and calculus starts to form, what happens? That bacteria literally eats away at the bone. I like to explain it to my patients like a Pac-Man. Some of them get a little giggle out of that. I said, I know I'm dating myself, but they get it. So the bacteria that's found in plaque and calculus literally eat away at that bone, right? And these are some of the signs and symptoms. Lately, as Nessa and I were talking before we started, patients coming in, some of us, our patients have been waylaid because of the pandemic. Some of them said they absolutely did not want to come in until they got their vaccinations. So I've been seeing people recently that I haven't seen in 18 months. I've also seen some new patients that are coming in with these exact symptoms. Hey, doc, I just wanted to come in. You know, you asked that question. Hey, Mrs. Jones, how are you doing today? Anything that's bothering you? Any concerns? And I've had several say, yeah, my gums are red and swollen, and sometimes they bleed when I'm brushing or flossing. These are the exact things that they say to me. Or my gums are pulling away. You know, they didn't look like that. Some people will say, oh, they look a little long in the tooth. That's their example of talking about recession. The other signs are loose or separating teeth. I've had patients come in that say, you know, doc, my teeth used to be super tight, but now I've got these spaces and, you know, I think I need braces. And what they don't realize is they have active periodontal disease. So that goes back to our education piece. You will actually sometimes see pus between the gums, you know, that pearl and exudate. Sometimes they will complain of persistent bad breath. Those of us who have been practicing any length of time will talk about perio breath, and we all know what that is. Unfortunately, some patients, again, they just don't know, and/or they haven't had the means or the time to actually come to the dentist. Some will talk about it's the way their teeth fit together. So not necessarily the anterior teeth that are flaring out, but maybe it's the posterior teeth that when they bite down, they don't quite fit together. Not that they're loose, but they don't quite fit together the way they used to. And this is always a good one, a change in the fit of their partial dentures. Now, you do have to ask, obviously, are you wearing your partials? Because as we know, when you don't wear them for a certain length of time, your teeth will start to shift a little bit. But the underlying condition absolutely could be underlying periodontitis. So what are the risk factors for periodontal disease? Here are some of them. Stress, absolutely. Smoking, and we know what that does, and nicotine literally strangulates the blood vessels. This is a new buzzword. I'm sure most of us have heard this term, but maybe just not have focused on it too much. Low socioeconomic factors. Then we have poor oral hygiene, medications, and poor diet. So let's talk about stress a little bit. Why do we think stress is going to put us at risk for periodontal disease? Well, when you're stressed, your body is in heightened states, right? So we're releasing all kinds of hormones. We're releasing things that our body's just not used to having to fight against all the time. And when that happens, that allows the pathogens in the mouth to become more numerous, different pathogens. So that's one thing. Smoking, we just talked about. Nicotine literally strangulates the blood vessels. And research has shown in the past, it can actually damage the cells to the point where they completely change. So if that's the case, then again, the blood supply is not able to get to the blood supply in the mouth. Low socioeconomic factors. How many of you still have patients that come in that haven't been to the dentist in, say, 5 or 10 years? I would imagine in the last 6 months or a year, pre-COVID, we had those patients. I know I still do. And some of them will tell you, well, I never grew up going to the dentist, or my parents never went to the dentist. The only time we went was when it hurt. So the whole idea of prevention is just not there. So when you think of low socioeconomic factors, sometimes it's the education piece, right? The health education piece that they're just not aware of. Poor oral hygiene. How many of us hear all the time, well, I brush twice a day, but I probably should floss more than I'm doing, right? My goal whenever patients come in is to encourage them. And I tell them this, especially the ones that are kind of holding their head down or sounding like they're a little bit ashamed. I say, you know what? Today is day one. And that means it's a clean slate. So let's go over the things that might be hindering you from ideal oral hygiene. And let's see if we can't come up with a plan. Medications, as we know, some medications, especially those that cause dry mouth, definitely are a risk factor. Some of the medications that can cause hyperplasia of the gingival tissue are risk factors. And then, of course, poor diet. And that goes back to sugary foods and drinks. So those are some of the basic things when we talk about risk factors for periodontal disease. And this comes from an article back in 2010. A destructive inflammatory disease of the supporting tissue of teeth. These inflamed periodontal tissues overproduce pro-inflammatory cytokines, mainly interleukin-1, interleukin-6, prostaglandins, and tumor necrosis alpha factor. I have to tell you, I thought, oh my gosh, I thought we were done with all of this, right? I don't know about you. I mean, I enjoyed biology, I enjoyed physiology, et cetera, but we got to the nitty gritty about these interleukins and prostaglandins and all this other biochemistry and biophysiology speak. It made me nervous. So I thought, no, are you kidding? But guess what? It's not as complicated as it sounds. In a nutshell, cytokines, when you talk about pro-inflammatory cytokines, what happens is the reason why we have this issue when it comes to periodontal disease is the body has an overactive immune response. And what happens, these things here that you see, interleukin-1, 6, prostaglandin, tumor necrosis factor, they come from the macrophages. You guys remember that back in biology, macrophage and ATP and all those things, Krebs cycle, that you thought we can learn it and we're done. You take the test and that's it. But that's where it's coming from. And the body says, oh my goodness, we need to get out there. We need to make sure we fight this. And they pour all that in. And unfortunately, what it does, it stimulates the osteoclasts. Osteoclasts do what? Eat away at the bone. And that's why it's a chronic issue. So here we go with cytokines. I think we're going to share this presentation later, but when you get a chance, this is a long video, about 11 minutes, so I didn't want to play it tonight. But it's really interesting explaining what cytokines do and a cytokine storm. So you'll find when you have diabetes as well as periodontal disease, that's why the two go hand in hand, because the cytokines, in this case, pro-inflammatory, are making the disease worse. So that's what's going on. They're immunoregulatory proteins that are secreted by the cells, especially of the immune system. It's an over-response from the immune system, and in our case, in a negative way. So that's what cytokines are. You will probably hear that term. We're talking about COVID right now, the whole respiratory issue, and the whole issue with cytokines there, and diabetes and COVID. The reason why people who have uncontrolled diabetes are so much at risk for the effects from COVID-19. So that's cytokines. Don't let it get you all worked up. It's not that bad. Just think back to biology and then biochemistry. And that's what cytokines do, okay, in a nutshell. So here's an article, very recent one, talks about the impact of periodontitis on the diabetes-related inflammatory status. It basically goes over what we just talked about. Again, it talks about cytokines, right? It says, type 2 diabetes mellitus and its complications through an ongoing cytokine-induced acute phase response, but also in the pathogenesis of periodontal diseases, okay, where the cytokines play a role. Has to do with the biofilm, it has to do with bacteria. So again, if the cytokines are acting the pro-inflammatory, they're destroying the tissues, but the bacteria in our mouth is still coming, right? Your AA, your PG, all those wonderful bacteria in the mouth, they're coming in droves, and that's why it's so destructive. Okay, that's the basic of what it's saying. It also talks about the immunobiological connection with type 2 diabetes and the infection with low-grade general inflammation. So it aggravates the insulin resistance. Okay, so that's the gist of how periodontitis and diabetes relate to inflammation. Here are some oral manifestations of poorly controlled diabetes, and I'm sure we all have seen this. The first one is oral candidiasis. We also call it thrush. And the reason why we see that is when you think about diabetes, again, it's poor sugar control. And what does sugar do if it's not controlled in the body? You get an overgrowth of candida or yeast. Those of you who have children or nieces or nephews, you may have heard the moms talking about the babies getting thrush. It's from an overgrowth of candida, which is fed by what? Sugar. So that's why we sometimes see that. We also see xerostomia or dryness in the mouth, and that's for the same reason. An overgrowth of sugar, the saliva is not stimulated enough, and you get xerostomia. When you have xerostomia, you increase your risk for dental caries, and that's what we see in this picture here on the right. A lot of times you'll get class 5 caries or root caries. You can also get burning mouth syndrome, which you see on the picture on the upper right-hand side, where the tongue literally feels like it's burning. And then, of course, gingivitis and periodontitis. So these are some of the things that you may see. Why is this important to us? So as we're examining the soft tissue and we do our head and neck exam and our oral cancer screenings and things like that, look for things like saliva flow. We just had a discussion with our students the other day, and it was a good reminder for me as well. Saliva should be flowy or watery, rather. Saliva should be watery. And you know, sometimes you'll have patients that say, oh my gosh, sometimes when I talk, I feel like I spit. And that, while that may be embarrassing, that's a good thing, because that means their saliva is flowing well, okay? Saliva is full of nutrients, and it's a natural buffer in our mouth for the bacteria. So as you're doing your examinations, you want to make sure that you see a pool of saliva, that you literally need to grab that saliva ejector because you see so much. But if it's bubbly or if it's ropey, or if you don't see a lot of it, this is when we want to have those conversations with our patients. And I'm seeing this in a lot of younger patients, not just the older patients, which is what we thought, that these things that we see come in people that are 45 years or older. That is not the case. So we are seeing it in everybody. Again, I know our back office team, which is our hygienists and dental assistants, are the first ones to actually sit down with the patients and have these discussions. But we as a doctor need to make sure we take the time and go over these things as well. So benefits of periodontal therapy on diabetes control. It can literally lower the HbA1c, the disease, chronic and oral gum infections. It removes the pathogens that can react with glucose in uncontrolled diabetes. It also improves glycemic control and improves glucose metabolism. So these are things we already know. As we remove those pathogens through scaling and root planing, right? They're not there to interact with the glucose. So therefore, we're seeing a big improvement. There's so many studies out there. If you Google it when we get off tonight, you'll see there's several studies out that talk about the improvement of oral health and also with diabetes control, glucose control with our SRP patients. And so again, we want to make sure we're educating them on the importance of their home care. As you and I know, our back office team can do everything to remove the calculus and the plaque and scaling and laser, et cetera. But if our patients aren't taking the time at home to make sure it doesn't come back, then it's for naught. So I also want to encourage you to have that conversation with your back office team about making sure they're properly educated on how to floss. A lot of them like to use those little floss picks, which you and I both know that doesn't allow you to really negotiate the gum tissue well. As we teach our students, and now we're saying it to our patients, you want to make that little C shape and get underneath the gum. You know how that works. So make sure you have that conversation with your back office team so patients have the tools they need to go home and really do their part. So diabetes, is it an epidemic? So this comes straight from the diabetes website, American Diabetes Association. The myth is that diabetes is not a serious disease. The fact is, it's a growing epidemic with a devastating physical, emotional, and a financial toll on our country. Look at this, it kills more Americans each year than AIDS and breast cancer combined. So of course, we're talking about the side effects or the things that go along with diabetes: kidney disease, retinopathy, neuropathy. Diabetes is the #1 reason for atraumatic limb amputation, fingers, toes, legs, because it's uncontrolled. So it absolutely is a growing epidemic. We'll talk a little bit of public health here about prevalence and incidence. So incidence is the total number of new cases of an illness at a specific period of time. So the incidence of the new cases of diabetes, say in Daly City, or the incidence of new cases of diabetes, say in California, that's incidence. And when has that happened over the last 6 months? Prevalence, on the other hand, is the total number of people with that certain illness at a specific time. So it includes everybody. Okay, so incidence is the new cases, prevalence is everybody. And when you look at that and you see this little diagram here, diabetes definitely is an epidemic because in the incidence of it, the numbers are rising, absolutely going through the roof. So I'm going to play this video for you. You may recognize the voice. It is Viola Davis. She is an Oscar-winning actress. I'm sure most of you have heard of her. And she did this video called A Touch of Sugar, I think about 2 years ago, because it runs in her family. And she is pre-diabetic. So let me just play a portion of this video for you and you'll hear her voice.
More than 30 million American adults are living with diabetes, and 90 to 95% have type 2 diabetes.
When you have diabetes, you have to do what you have to do. I mean, it's not a disease that goes away. It's 365 days a year, 24 hours a day.
I woke up I couldn't see. My head was pounding. My body felt like I was walking underwater. I didn't know what was going on.
It never passed through my mind that I'm going to have diabetes, even though I know that I have it in my genes because of my family history. I never know that I would be diagnosed with diabetes.
When they told me I was diabetic, he gave me a pamphlet. And that was it.
This isn't a problem, this is an epidemic.
There is a semblance of shame that is forced upon people with diabetes. I didn't choose to get diabetes.
If current trends continue, by 2030, the prevalence of diabetes in the United States will increase by 54%.
Why is it important to stand up for diabetes? Because nobody else is doing it.
My life passion now is to educate as many people as I can about diabetes.
We all need to sound the alarm. Sound the alarm and help awaken the rest of the world to the seriousness of this disease.
Life is not over. It's not over. This is not the end of your life.
Walk proudly. And you can manage it.
So that's a snippet of it. It's a wonderful documentary. And again, it's about raising the awareness. I'm sure everyone on this call tonight has been touched by this in some way, if not directly, if not in your immediate family. I'm sure you have friends, loved ones that have been affected by this. So it's definitely a message that needs to get out.
I am one of the 8.
So here are some of the statistics. This is the most recent one from the CDC. More than 122 million Americans are living with diabetes or pre-diabetes. Could it be you? A little bit of my own personal story. I am pre-diabetic. It does run in my family. My father, when he passed away back in 2009, unfortunately had diabetes. And so as Viola mentioned, the good news is 90 to 95% of the population who has diabetes is type 2, which is completely preventable and in some cases reversible. Okay, so be of good cheer. As the young lady said in the video, it's not a death sentence. We can do this, but we need to spread the word. Okay, so when it comes to pre-diabetes, 1 out of 3 Americans are pre-diabetic and they don't even know it. 1 out of 3. 88 million adults, 1 in 3. When it comes to diabetes, it's 1 in 5 and they don't know it. 34.2 million people. So why in our healthcare, in our field, is that an issue? Well, we'll see it a little bit later, but we, as dentists and dental hygienists in the dental field, typically our patients will see us at least once a year. They may not see their primary care. So we have a perfect opportunity to share with them the importance of getting screened. And I will show you in a little bit how we can actually screen patients, at least do a test online to help them see what their risk factors are and that they should be checked. Just like you go in to have your cholesterol checked and those other things checked, we should be checking to see if you're at risk for diabetes. When I say we, the healthcare industry, obviously in the dental office, we're not going to confirm that you're diabetic. We will refer appropriately to their primary care. So again, the CDC says diabetes is a chronic health condition and it does affect how your body turns food into energy. National Institute of Health and the National Institute of Diabetes and Digestive and Kidney Disease define it as a disease that occurs when your blood sugar is too high. So we're going to talk a little bit about how that happens. It is a chronic health condition. So let's go over the types of diabetes. Type 1, which some of us may have remembered as juvenile diabetes because it typically happened when you were young, is now called type 1. The body does not produce insulin. And now they say it can happen at any age. I have some family members. I have a couple of really great friends that are in their 40s and 50s that just found out that they are type 1 diabetic. So that could be one reason why they changed it. I'm not sure, but it's just easier to keep track of it that way. And as you see, it affects only 5 to 10% of the population. Apparently, when you go in and you're checked and your blood sugar is a certain level, if they're concerned, they do a different test. I'm not quite sure how that works, but that's what my very good friend shared with me, that her mother shared with her. That's how she found out. Type 2 is the body does not use the insulin. So let's go back to type 1. Type 1 means you don't produce it. It's actually sort of an autoimmune issue. Your body doesn't regulate, and the pancreas literally does not produce insulin. Whereas type 2, the body does not use it properly, or we call it insulin resistance. It's the most common, and that's why you see it in 90 to 95% of the population. Okay. The third type is called gestational, which affects pregnant women, and it does affect nearly 10% of all pregnant women. The last one, and this is new, type 3. You see, I put a question mark. And if you start doing some research, you'll see online, Google diabetes and Alzheimer's disease, you will see that they're starting to call it the type 3. There's a definite connection with Alzheimer's disease and the tau protein, which is one of the proteins found in the brain post-mortem in Alzheimer's patients. I remember reading another article about a year or so ago about a bacteria called treponema, which is found in the oral cavity. And another case where they did a post-mortem and they found that bacteria in the brain. So there is definitely a connection. And now they're actually looking to call it type 3 or Alzheimer's related diabetes. So that's what's new in the horizon. Warning signs of diabetes: excessive thirst. I like to actually qualify that and say unexplained in the same way you see I wrote unexplained frequent urination. For those that are really into exercise and working out, you're going to be thirsty, right? So I say excessive thirst, but I would also say unexplained, extreme hunger, even though you're eating, unexplained frequent urination. So again, if you're drinking a lot of water, you're going to be making a lot of trips to the bathroom. Blurry vision. This is not just the, oh, I need to go get my eyes checked or my glasses aren't working. It's blurry vision that's just out of the blue. The other one is extreme weight loss, especially with type 1, even though you're eating. Tingling, pain, numbness in the hands and feet. That's an example of type 2. So it's that consistent thing, right? It's not just, oh, I pinched my finger. Oh, my hands feel a little bit numb because I was working so long. It's the consistency where, you know, something just doesn't feel right. And then, of course, this is another big clue here. Cuts or bruises that are slow to heal. And we know that when it comes to diabetics, that is definitely a sign because, again, the blood sugar, it just doesn't allow the body to heal like it should. So if you know of anybody, or if you yourself are experiencing any of these symptoms and you have not been screened, and in this case, I'm going to definitely encourage you to have an HbA1c blood test. We'll talk about that in a minute. Please go take care of that. And if you have any loved ones or friends or family that you're thinking, oh, that sounds like cousin so-and-so, or that sounds like aunt so-and-so, have this conversation with them. And if you have to, maybe go with them, because sometimes people are literally scared to find out what's really going on with their total health. Type 1 risk factors, if there's a family history, or if you have a parent or a sibling with type 1. The other one is age. And again, while it can happen at any age, it does typically develop in children and teenagers and young adults. And in the US, it's more prevalent among whites than African Americans and Hispanics and Latinos. Type 2 risk factors, being overweight. So that's why you'll hear for people that are type 2, or in my case, pre-diabetic, what are the things I can control? Losing 10% of my body weight. What does a doctor tell us? We need to be exercising, moving 30 minutes a day, 5 days a week, 150 minutes a week. If you have a family history of type 2 diabetes, you are more at risk. This one says age 45 or older. I will show you in a little bit that that number is actually dropping considerably. And a lot of that has to do with inactivity with our young people and, quite frankly, childhood obesity. So that number is really dropping. Gestational diabetes we talked about. So if you had gestational diabetes, you are at risk for type 2. Doesn't mean you'll get it, but you are at a higher risk. Physical inactivity. And then we do see it more in certain ethnic and racial backgrounds. So those are some of the risk factors. Again, something we should be aware of, conversation you can have with your patients, and definitely within yourself and your family. So these are some of the blood tests. Diabetes screening blood test. You've got 3 different kinds. There's the A1C test, there's a fasting blood sugar, and there's one called a glucose tolerance test. Let's start with the A1C. The A1C, which is hemoglobin A, looks at the glycosylated glucose. What does that mean? It's looking at the way glucose attaches to your red blood cells over the last 2 to 3 months, because our red blood cells turn over every 2 to 3 months. And it's looking at that. It comes in a percentage. And as you see, if you are below 5.7, when you have an A1C blood test, completely normal. Between 5.7 and 6.4, you're considered pre-diabetic. Anything over that, 6.5 and above, you are considered diabetic. Fasting blood glucose. So that's when we go to the doctor. And a lot of doctors now are saying, you don't have to fast, even when they look at, when they're checking your blood sugar for today. So that's what fasting blood glucose is let's see what your blood sugar is today, right? Excuse me, just grab a sip of water here. Fasting means that you haven't had anything to eat or drink for at least 8 hours. For those of us that go to the doctor and they tell you, oh, you've got to fast, and they say 12 to 14 hours, and we think you just can't make it. Technically, it's anything at least 8 hours, a minimum of 8 hours. So what we're looking for, what your doctors are looking for, is anything below 100. That's normal range when you've been fasting. If that number is between 100 and 125, you're considered pre-diabetic. And again, if it's over 126, you're considered diabetic. Excuse me. So a lot of times what will happen is you may have a fasting of 126, and then they'll look at the A1C and they'll look at those two together. My primary care prefers the A1C. She feels that's more accurate, but she does always encourage me to make sure my blood sugar is close to 100. I do check my blood sugar 2 to 3 times a week. I am pre-diabetic, as I mentioned earlier, but that's the only way we know, right? That's the only way we know if what I'm doing is working. My goal is not to get to type 2. So how do I know if that's working? Check your blood sugar. And then the glucose tolerance test typically is done during pregnancy, where you have to drink this wonderful, not so wonderful drink. It's very, very sweet. Then they have you wait 2 hours and come back and check your blood sugar. And based on these numbers you see here, we'll let you know if you're either normal, pre, or if you're diabetic. So this is where you hear about gestational diabetes, okay? So random blood glucose is taken at any time, right? You don't need to fast, and it should not exceed 200 milligrams. If you've eaten, your blood sugar is going to go up, but it shouldn't go above 200 milligrams. So those are some of the things to keep in mind. Again, if you have not had an A1C blood test in the last 12 months, or if you know of your loved ones or friends or family, please encourage them to go get one. So what does the evidence say? This came out last summer. This is from the National Diabetes, this is from the CDC, the National Diabetes Statistic Report in 2020, which was released in June of 2020. But it looked at the numbers back from 2018, 2013, and 2016, okay? I circled this. Well, let's go back. So total age. So typically we used to be concerned if you were over the age of 65. Then that number changed between 45 to 64. Now the number starts at 18. So let's look at these numbers. This says pre-diabetes between 2013 and 2016. The average age, or the average number, was 24.3. That was the number of cases per million, right? Look at the pre-diabetes in 2018 for that same age range, 18 to 44. It's 28.7. It is going up. Why is that? Childhood obesity. My niece finished her residency in peds at Kaiser Oakland year before last, and that's exactly what she was dealing with, childhood obesity. Why is that? Well, because her kids are at home doing this all day or on the computer all day. A lot of us grew up where our parents made us go outside and just have fun, play out in the street with your friends, go to the park. That doesn't happen a lot these days. Sedentary lifestyle with kids, and that's what's going on. The age of 18. So even though I shared with you earlier, age 45 is a risk factor, we really need to be looking at our young people. So those of us that have children or nieces or nephews or anyone that you know that you can speak into their lives, start having this conversation about healthy lifestyle. 28.7 million from 24.3. Unbelievable. And anywhere from, if you go back to 2013, over the last 5 years at that time. So this is the most recent data. That's what the evidence says. The numbers are going up. You will also see here, you see it more with women than you do men. And when it comes to race and ethnicity, 54.8 for white non-Hispanic, 11.4 for Black non-Hispanic, 5 for Asian, and 14.6 for Hispanic. These numbers are going up. So oral disease can complicate systemic disease. We talked about this. It's a two-way street. This is a great article here. This goes back to 2005. You'll find that the current articles are saying the exact same thing. You'll see right here, diabetics are 2 times, 4 times more susceptible to gum disease because of the poor blood glucose control, which we already know. High blood glucose levels make fighting infections more difficult. And that's the other reason why, not just in the oral cavity, but that's why we talked about wounds, hands, feet, cuts. You'll find people that are diabetic will wear certain shoes because they don't want to run the risk of causing cuts in their feet, right? Poorly controlled blood sugar has an adverse effect on periodontal disease. We just talked about that. 2 to 3 times more likely. People with type 1 or 2 and prediabetes should be carefully monitored. They need to monitor themselves. So I always share with my patients, as much as I'm here to help and give them information. At the end of the day, they've got to take the responsibility. And that's how you'll know. When you start asking your patients that are pre-diabetic or diabetic, it's interesting. How was your blood sugar today? Those that are diabetic, oh, I didn't take it today. Okay, well, how was it yesterday? Oh, I didn't take it yesterday either. I remember, let's see, probably 20 years ago, well, when I used to practice with my dad, so that was before 1998, I had a patient that was type 2 diabetic. She was checking her blood sugar 6 times a day because it's before and after you eat. So I'm not quite sure what's happened, but that seems to be the norm now, that people are not checking their blood sugar. So they don't know. They have no idea. That's how we know if their blood sugar is controlled or not, though, because they should know their numbers. Absolutely should know their numbers. What's the common denominator? Inflammation. At the end of the day, that's the common denominator. There's something called C-reactive protein. Some of you have probably heard of that. And it just goes to show if you have inflammation in your body. For those of us that may have high blood pressure or any other inflammatory diseases, rheumatoid arthritis, for instance, if you had a test for C-reactive protein, it would come back that it's high. So in that case, it really didn't help you a whole lot, but it's just something to know that that's one of the things that you will see. We talked about the cytokines earlier, in particular, interleukin-6, interleukin-1, and tumor necrosis factor alpha, all part of the macrophage family. So just keep that in mind. That's a common denominator, is inflammation. Most of us have some kind of inflammation going on in our body. It's either our joints, it can be our teeth and gums, it can be our liver, it can be the things that if we're taking medication, most of us have some kind of inflammation. So that does definitely put us at risk. So let's get back to the basics. We've got to make sure we're taking the time, that our staff, our back office is taking the time to actually discuss and demonstrate how to floss properly, okay? Gum disease is listed as the 7th complication in diabetes. So reviewing the basics and importance about brushing and flossing is key, right? Ask the patient the following question. Tell me about your brushing and flossing habits. What do you use and how often? So I put it that way. We call that an open-ended question versus, are you flossing? Are you brushing? One, you have to ask too many questions, but two, my goal is to really have them tell me, give me more information without me having to drag it out. So that's one of my favorite questions to ask. You may have some others that you like to ask, and feel free to share that in the Q&A. I'd love to share information with each other, but that's one of my favorites. Tell me about your brushing and flossing habits. What do you use and how often? Typically, they'll say, oh, I brush twice a day and I floss 3 times a week, and I floss every day. So what I found lately is when people say that, then we go and we do their periodontal evaluation. You know, we're doing the probing depths, and they've got a lot of 4mm pockets, especially in the posterior. Then we find out, well, what do you use to floss? How are you flossing? And most people don't floss properly. They either don't floss properly or long enough. They love those little sores where you can just go in between your teeth, in and out, in and out, in and out. And they don't go all the way under the gum. I will also ask them the question, so tell me, what do you think is the purpose of flossing? And 7 out of 10 will say, oh, to get the food out between my teeth. So of course, as I shared with you earlier, I like to be encouraging. So I said, well, that's true. But the other reason why, and I explain it to them, I actually tell them about floss removes plaque where the teeth touch that can cause cavities. It also removes plaque underneath the gum that causes gum disease. And I think what happens is when people get the why behind the what, it helps them to affect change. It helps them to change their behavior or encourages them to want to change their behavior. Okay. This says use your chairside instructor as a visual aid. I still have one. But most of us have computers in the operatory, use some kind of visual aid. I have a chairside instructor. I have one of those flip charts, but I also have a computer where I can pull up a picture of periodontal disease and pull up flossing like you see here. Then we actually demonstrate it in the mouth, and I say, have them demo back. Give them the floss and let them show you. Why do we want to do that? Because if we don't get those basics, all the things, all the time, all the information that we're sharing with them, that our back office team, that our hygienist is really trying to really get into people's heads and brains, it's going to go by the wayside. They have to take ownership. And I find when they do, I want to invite them to take ownership, that they realize they're partnering with us. We're partnering with them, I should say, in their oral health. It makes a tremendous difference. And you know what? Probably those same 7 out of 10 say, no one ever showed me that before. Because typically we say, are you flossing? And patients say, oh yeah. And then we just go about our business. So that's why, get back to the basics. Diabetes and gum disease, as we mentioned earlier, when it comes to diabetes, gum disease is listed as the 7th complication. You have obesity, eye disease, kidney disease. So when you talk about eye disease, we're talking about retinopathy. Kidney disease, you're having poor kidney function, kidney failure. Nerve disease, which is neuropathy. Cardiovascular, of course, we know about high blood pressure, skin conditions, and depression. But look at this, gum disease is listed as number 7. So what we want to do is make sure we make an appointment with your dental care professional immediately. These are things we can share when we're out and about. So I know a lot of us like to be involved in things in our community. Whenever you're involved in those kinds of community activities, whenever you're doing screenings, make sure you share this information, okay? Of course, we know during the treatment of the process, the biofilm is removed. All of that we talked about before, right? So again, gum disease is a 7th complication of diabetes. That's why it's so important we get this message out and encourage people to get screened and tested. Nutrition. I just put an alarm at 7:30, so we'll know to take a stretch break. I will finish with this slide and then we'll take a little 5-minute stretch break, okay? So nutrition, let's go back to the basic things that we were taught in dental school that we know about. Facts about sugar. So this is a great picture here. Less sugar, sweeter life. Talks about how many grams of sugar there are in, say, a can of Coke, or how many grams of sugar there are in some of these sugar-free drinks, or just all those kinds of things. So we need to make sure we know that, right? We call it less sugar, sweeter life. Think before you drink. I had a patient come in yesterday. What's today? Yeah, yesterday, new patient, hadn't been to the dentist in about 5 years. And she needs root canals on, let's see, teeth, about 5 teeth. She has had a root canal on 2 teeth, needs crowns, et cetera, et cetera. Her chief complaint was pain on the upper left side. And as I talked to her and interviewed, et cetera, I knew before I looked in her mouth, I was probably going to see a really deep cavity. Long story short, that's what we saw. So do you think it's enough to tell her about brushing and flossing and making sure she's brushing and flossing? That in itself is not going to work. So what I did was I said to her, I just asked her, I said, so how do you think these cavities got here? And I wasn't asking in a condescending manner at all. I really wanted to get her feedback. How do you think you got these cavities? She knew before she came in. She said, I know I've got cavities. I want to get them fixed. And when I asked her, she said, I don't know. I said, okay, well, let me ask you a different question. Other than water, what do you drink throughout the day? And you know what her response was? Oh, I drink a lot of diet sodas. I said, okay, so now we're getting somewhere, right? I drink a lot of diet sodas. I said, okay, about how many do you think you have a day? Well, probably 2 or 3 throughout the day. I said, okay, anything else that you drink? Well, I like to drink coffee. Okay, and what's in your coffee? Sugar and cream. All righty, and between that and in the soda you just mentioned, how much of that? Maybe a cup or 2, but again, I drink it throughout the day. So one thing that we're learning, and there's one thing that we teach our students is, as I mentioned to you earlier, saliva is a natural buffer, right? We all have acidity levels in our mouth, and it would be good to get that checked. You can do that with a litmus paper. If you are constantly snacking all day, drinking things other than water that can make your sugar level and acid go up and down, that buffer never gets to work. So I said to her, and she kind of looked at me. I said, well, what are your thoughts on making some changes with that? She said, oh yeah. I said, well, I could say, hey, we need you to stop that. First, I backed up and told her the other reason why we're not crazy about soda. It's not just the sugar, because when you look at 8 ounces of soda and you look at 8 ounces of apple juice, the amount of sugar is very close. It's the phosphoric acid that leaches calcium from the teeth and bones. So I said to her, what do you think about going down to 2 sodas a day? She said, I could do that. And I said, and do you think you could add a glass of water in between? She said, I could do that. So see, instead of her saying, okay, doc, I'm going to cut cold turkey, which she might say, and she might mean, but the behavior and the chances of that changing right away are not necessarily going to happen. So let's talk about a compromise. And those are the conversations we need to have with our patients, okay? Those are those conversations. So she agreed, and she seemed very motivated, and we got things going. We got a plan of action, and that's where we are. So I just want to share that story with you because, again, I'm sure quite a few of us have seen that, and I want to make sure that we're taking the time to have those conversations. It's up to us to educate the patients on things like nutrition. What are some alternatives? I drink water. Right now, I've got water in here with a lemon essential oil. Sometimes I'll put wild orange because that gives me the fruity taste that I want. I know we all sometimes want that kind of sweet taste. I'll actually have sparkling water with a drop of tangerine oil. So I get that sweet that I want without all the sugar. So those are things that we really want to talk to our patients about and just help educate them so they can make better choices. So who's at risk? And this is where we talk about social determinants of health. Socioeconomic factors, underserved and underrepresented communities, and diabetes risk assessment. How did we get here? According to the American Journal of Public Health, and this goes back a ways, distinct oral health disparities and inequities continue to exist among low-income, racial ethnic minority groups, basically underserved. That's been going on for years. People who live in urban areas, people who live in rural areas, people who just don't know, right? People with disabilities, intellectual and developmental disabilities. Those are people that are affected. Oral health disparities and the impact. The unmet oral health care needs of adults aged 20 to 64. Look at that. 40% low-income adults have untreated cavities. 80% have unmet needs. They report that they couldn't afford care. And so some of us know, being here in the Bay Area, being in California, we have all kinds of programs. We have Healthy Families, we have Medi-Cal. Medicare covers medical, but it does not cover dental. We do have at the dental school, UOP, we do accept Medi-Cal. So, and there's a lot of clinics, there's a lot of public health clinics that accept either sliding scale or take different insurances. So again, it's about letting the public be aware that they do have options. So here's the test that's online. Are you at risk for type 2 diabetes? This is straight from the American Diabetes Association website. And this is something you can do in the office. We do this in our office with every new patient and our recalls. We'll go back and we'll see, are they at risk? We do the online test. This is addressing health disparities in diabetes. This is also very recent, straight from the CDC. And again, remember we talked about now that number is going down to age 18. You will see this. It says percentage of US adults age 18 or older with diagnosed diabetes. And this is between by racial and ethnic group from 2013 to 2015. Look at the numbers here. American Indian and Alaskan Native are the highest. Asian American are at 8%, Hispanic. You see the numbers, Black non-Hispanic, white non-Hispanic. Okay, this is their report card. And then you look at the number of people age 18 or older with diagnosed diabetes by education. So education has a lot to do with it. Less than high school, look at those numbers. High school, 9.5, more than high school. So the more education people have, the more they can make better informed decisions. Here's an example. I love this picture of the difference between health disparities and health inequalities. This is something I had to wrap my brain around as well. So when you look at this picture, look at the equality, right? They all have something to stand on. So that's equal. But when you look at the equity, look at that. So that they all could see over the fence, they had to change things around. So there's a difference between equality and equity. And this comes from Healthy People. Healthy People was released by the Department of Health and Human Services back in 1980. And it was a way to say, this is the goal that we have for our country and how to get healthy. And every 10 years, they release a new one. So you had 1980, 1990, 2000, 2010, 2020. And even though 2020 just passed, there's a Healthy People 2030, because we have to be looking ahead. So Healthy People 2020 talks about health disparities as a particular type of health difference that is closely linked with social, economic, social, and environmental disadvantages. We'll talk more about that. There's actually an organization through the United States Department of Health and Human Services called the Office of Minority Health, because they realize when it comes to different ethnic groups, you need to address it from a different perspective. So let's give an example. So we say we want to eat more healthy greens. Well, healthy greens in the Black and African American community may be different than in the Asian American versus Hispanic. So for instance, my husband and I are a fan of bok choy. We also like collard greens. We also like spinach. So depending on your background, right, when you're talking about health, you have to make sure you dress it in a way that's specific to those individuals in that specific community. Here's another example, the Office of Minority Health. So for instance, let me go back. That's okay. So we talked about, you saw where you could see the different breakdown. So for instance, if you look at this profile of Black and African Americans tend to be in this states, okay? And then you could click on any of these on the left-hand side and look to see, okay, what's the issue with asthma, with cancer, with all these things, and how do we address that? Especially when you know it's going to be in different states, it's going to be affected in a different way. Social determinants of health. So most of you have heard this, you just don't realize you've heard this. When I first learned about it the last few years, I thought, wait a minute, we talk about that all the time without using that label. But this is what social determinants of health are, SDOH. It pretty much is where we live, where we're born, where we live, work, and play, okay? So starting off here, and we've got other slides that will break it down, but where you grew up, your neighborhood and the environment around it, healthcare, health and healthcare also includes health literacy. We look at their social and community context, education, and economic stability. So neighborhood and built environment. This is a snapshot of the Bay Area, San Francisco Bay Area. For instance, your quality of housing, depending on where you live. Is it safe? If you live in a neighborhood where you don't feel safe, and unfortunately these days, I'm sure you follow the news, not too many places are safe. You hear about people walking down Market Street. You heard of the attacks on the Asian community. But if you live in an area where you don't feel safe, then you're not going to go outside. You're not going to take your walk. You're not going to get your exercise, right? Is there adequate heat? What's the air quality like? Certain neighborhoods, you have more poor air quality, the mold, the asbestos. Look at the homeless problem we have right here in San Francisco. That's social determinants of health. Education, language, and literacy. When it comes to literacy, it is so important that we have things in a language that people can understand. Being here in San Francisco Bay Area, we're extremely blessed with the diversity that we have. We have so many different ethnic groups, and the wonderful news is that we have so many different translators. Almost every language you can think about. The CDC has the Are You at Risk for Diabetes test on their website in over 13 different languages. And when you click on that, especially if you click on Asian, it's broken down to Vietnamese, to Chinese, to Japanese, to Humalog, all kinds of languages, and there's interpreters. So it's key that education is in language that people understand. Economic stability. Look at what we're going through right now, the businesses that have closed because of COVID. Are you employed? Employment obviously plays a role, because if you have to choose between employment or taking yourself or your child to the dentist, that's going to make a difference, right? If you're in a situation where you feel like you can't miss work because you could lose your job, going to the dentist is going to be low on your priority list. Comes to education, we're looking at, again, skills. Do you have a job, your benefits where sick leave is paid? All those things impact it. Social and community context. So this is an example, for instance, at Pacific, Dagoni, where we do a senior smile. We do it every year. Needless to say, in 2020, we weren't able to do that. But this is an example of what you can do right in your community. So civic participation, being able, again, to educate patients on everything. We hold it at the dental school. It's not only oral health. You'll see by this flyer, it's blood glucose, it's hearing, it is balance and flexibility, bone density, things like that. So what's going on in your neighborhood? Health and healthcare. Look at this. This is Healthy People 2030. And you'll see, this is an example, right? Again, the goal is to make sure that everyone has adequate access to everything, right? So access to healthcare and health literacy. We talked about that earlier. Dentical and healthy families. We have that right here in California. In certain counties, in San Mateo County, we have healthy families. In San Francisco, it's called something else. Do you have limited healthcare resources? How do you know what's available? That's where we come in. That's where we come in. That's where our front office team comes in, where we can share this information with our patients. What about access to transportation? If it's going to take 3 buses for you to get to the dentist, if you live, say, in South of Market and you have to get all the way out to Stonestown, it may take you a long time and limited hours. How many of us have evening, weekends, etc., right? So the good news is there are safety net clinics. Pacific Dagoni is one of them. And there's a lot of community health clinics. So again, it's a matter of helping to educate our patients. But this is all social determinants of health, access to healthcare and health literacy. So these are some of the perspectives from the hygienist when they're talking about diabetes and gum disease or periodontal disease. And you see some of the questions that they ask. We talked about that earlier. What would you say your diabetes is controlled? When was your last blood glucose? What medications are you taking? Did you eat today? Very important. When you do know you have a diabetic patient, not only ask, did you eat? Ask them, what did they eat and what time did they eat? Because maybe it's been 4 hours. So you want to set them up for success. You want to make sure that you have that conversation. And if you're not sure at all, please make sure you have a glucometer in your office so you can check your patient's blood sugar. Screening for prediabetes and diabetes in a dental setting. So there were studies done on this. And as I mentioned earlier, because most people will come and see their dentist at least once a year, we are primed to be able to do this screening, okay? It literally will take you 2 minutes, your back office, 2 minutes to do this test. This is that study, the Haynes study from 2013 to 2016. And in a nutshell, it basically says that more people, there's a percentage of people that found out that they were pre-diabetic and some of them diabetic. So of course we don't diagnose, remember, but we screen. So if we do the screening questions and then we refer them to their primary care, now they can find out if they're pre-diabetic or diabetic. And so that study was amazing. It proved to serve itself very, very well. Oral health disparities, we talked about a little bit. Again, this goes over that report. It shows that twice as high in untreated dental caries among Hispanic and non-Hispanic Black children as compared to non-Hispanic white children. And it goes back to the things we talked about. So oral health disparities, social determinants of health. Why is prediabetes and type 2 diabetes a connector? We mentioned this earlier. Prediabetes is associated with increased risk for cardiovascular disease, stroke, and coronary disease. Again, you can go from prediabetes to type 2, and type 2, unfortunately, is a major contributor to the morbidity that we see. So again, an opportunity to share this message with our patients and our loved ones. Can diabetes cause complications with other body functions? Yes. #1 cause for atraumatic limb amputation, kidney failure, adult onset blindness, drastically increases your risk for stroke and heart attack. For some reason, unfortunately, they just kind of go together. The good news is type 2, completely preventable and in some cases reversible. What happens when someone discovers they are at high risk for prediabetes and or diabetes? So I shared with you, that's my case. I'm a work in progress. You see right here, for every 10 patients screened age 20 or older, 2 are found to be at risk. 20 or older. And that goes back to what we talked about earlier, is the whole sedentary lifestyle. So have this conversation, refer them to their primary care, and we can share materials with them. We can have brochures in our office. We can go to the website. The goal is to have our patients armed with information. Here's American Diabetes Association. When you go to the website, you see the test right here. Are you at risk? And American Dental Association has its brochures out that we can share with our patients. And here's what the American Dental Association has to say. Again, it's that study that we talked about. We already know about the gum disease, the red swollen gums, the things that the signs that we talked about, the pus between the teeth, thrush, wound healing. So that means that your patients are at risk for healing from a simple extraction, right? When it's not well controlled, it can slow down that process. From scaling to root planing, a lot of us see our patients when they've had a simple cleaning, how much their gums bleed. So that is huge. That's why we want to make sure we get this message out. What can be done to raise the awareness of prediabetes and diabetes? Decide today that you're going to start this program. It's so easy. You just show your team how to do it, take the test yourself, and then we can be that intermediary to help point people in the right direction. Perform screenings or risk assessments in dental settings. That can be in your dental office, that can be at the dental school, that can be at a health fair. I want to encourage all of us to get back involved as things start to open up in health fairs. It might be doing something like this with your local organization that you like to volunteer at. Offer to host an online webinar. So this is what the test looks like, American Diabetes Association. And again, if you click on that link, when you click on it, this is one of the first things you see, and you just go through it. Is it for myself or is it for someone else? It'll ask you how old you are. You click on the answer. What is your gender? You just click on the answer. It literally takes 2 minutes. Do you have a mother, father, sister, or brother with diabetes? Remember, we talked about this earlier. It does increase your risk. It's not genetic. I have patients that come in and say, oh yeah, it's genetic, but it's not genetic. It's what we call familial. And because we see that, it does increase your risk. But again, once we know, that's when we can make a difference. So this test doesn't take long at all. I show you this because after we do that test, let's say it comes back and it says you're low risk. Then the next thing I do is I click on the one that says A1C. So I explain to the patient what an A1C is. And as I shared with you, it looks at the amount of glucose in your blood over the last 2 to 3 months. I'll ask them, have you had an A1C blood test? 9 times out of 10, they don't even know what it is. So the answer is no. But every now and again, I'll get an answer back. So I specifically say, make sure you contact your primary care. Let them know you went to the dentist. We had this conversation because you are 3 times more prone for gum disease, put it in their terms, if you're a diabetic and you want to know what your status is. And then sometimes I'll have them write it down, but it's just a matter of literally sharing that information with them. And I challenge all of us on this call, if you have not had one in the last year or had one at all, contact your primary care when we get off this call, send them an email so you can set this up for yourself. Questions to ask your diabetic patients, you pretty much know what they are. How old were you when you were diagnosed? How long has it been since the diagnosis? What medications do you take? How well do you monitor your blood glucose levels? Ask them, of course, their most recent A1C, and how often do you see your doctor? This gives you an indicator if they are controlled. Hopefully they come back with a resounding yes. Medical concerns are things we just talked about. Is your patient showing signs and symptoms? Definitely refer them to their doctor. And then self-reported diagnosis of diabetes. You want to ask which type. You need to make sure you put that in your SOAP note, type 1 or type 2, get a thorough history and document any complications that they told you about. Sometimes we have to ask that, any complications, have you been hospitalized? Because a lot of times patients get so used to saying no, 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 until you ask a specific question, they may not have that answer for you. Become familiar with medications. We can look them up, but you'll hear things like metformin, common oral medications, or metformin and glipizide. They'll tell you if they're taking insulin, if it's long acting, if it's short acting. So become familiar with those. Of course, we can always look them up. We can go online to check that out. And then know that some patients are using different delivery systems. Some are on an insulin pump. This is a really unique device where you literally can have it into your skin and insulin is delivered through there where they don't have to poke themselves every time to deliver it. It's really great for typically type 1 diabetics. My dad talked his primary care into letting him use it, being type 2, because he was pretty busy and traveled a lot. But you'll know that some patients are on what's called a pump. Be familiar with that. There's also something else called continuous glucose monitors. We may have some people on this call that are using those, or loved ones that are. My god sister uses both the Dexcom and the Libre. The difference is with the Dexcom, which you see here on the left, it's a transdermal type of device. It literally checks your blood sugar every 5 seconds, which sounds like a lot, but when you're trying to decide what I ate or what to eat, and you can see exactly what your blood sugar is, then you can make a more informed decision on what you're going to fuel your body with. I believe she has to change it every 14 days. The Libre, which you see on the right-hand side, is a disc. It's usually on the arm, and you actually have to take the device and wand it. The Dexcom is connected to your smartphone, so it makes it a whole lot easier. These are things you want to be familiar with. And then these are some instructions we want to give our patients, okay? Make sure you instruct them to eat a normal meal before their appointment. For some reason, some patients decide not to eat. I know if I was going to the dentist, especially if I know I had to get numb, I'm going to eat. Make sure you tell them to bring their medication and their form of glucose with them, because ideally, If they, for instance, if they're taking insulin, we would want them to be able to use that, have early morning appointments. But here are some things that we know that help with your blood sugar. Orange juice, all of us either have the glucose tablets or the glucose paste in our emergency kit that we can help patients with if we're concerned with low blood sugar. And again, we want to make sure we have the appointments early in the morning, confirm that they did check their blood sugar, what time did they eat, if they had breakfast, what they ate, and then make sure you have a source of glucose in the office. So we can have some people call it frosting in our kits, but I just always like to have a small bottle of orange juice in my refrigerator because that is the quickest way to get glucose into somebody's system, okay? And make sure you have a glucometer, which is normally not part of your kit, but I encourage you to get it, test it. I promise you, you won't die. It's not that bad checking your blood sugar. I will give you some tips though. Instead of checking your blood sugar right on the tip of your finger, check it a little bit on the side. It doesn't bother, it doesn't hurt as much. But if it's right on the tip, I also use it on my non-dominant hand. It's really not a big deal. Post-op appointment instructions, remind them to follow their usual protocol, make sure they take their medication and eat, right, like they normally would. Obviously, if they're numb, you want to caution them to wait until it wears off, but they should definitely eat their normal protocol. These are soft foods. You can definitely encourage them to have soft foods. These are healthy smoothies, but you do want to encourage them to eat a normal meal. So what's the most common complication in the dental office? Hypoglycemia, when someone has low blood sugar, right? That means their blood sugar has fallen below 60, and you'll see all kinds of signs and symptoms with that. Hypoglycemia in the dental office. Oh, and to avoid that, you do want to try to have short procedures. If it's less than an hour and the blood glucose has been 100, then you're usually good. If it's a longer procedure, you're doing implants and you're just not sure, you definitely want to check their blood sugar in the middle of the procedure. It's not going to hurt because that's the biggest thing you don't want is having someone have a hypoglycemic attack in your chair. I mean, we know how to deal with it, but we can avoid it, right? And then knowing what those minimal blood glucose levels should be. If you're not sure, check their blood sugar. If you don't feel comfortable that the patient has given you accurate information or they seem to be acting a little funny, stop, check their blood sugar. So what do? How do we share this with our patients? Again, we talked about the dental setting, which we already talked about, making sure you're having that conversation. And because they're in our dental chair at least once a year, it's easy for us to share that information. Discuss the diabetes and periodontal disease connection. All these things that we talked about. Your patient may say, why are you asking me questions about my diabetes? I'm not diabetic. So these are some of the talking points that you can say. Research shows diabetes and oral health are connected. The whole thing we talked about with the 84 million people and the 34 million people, I think I said 88, those numbers are changing all the time. The fact that diabetics are 3 times more susceptible to develop gum disease. And of course, uncontrolled gum disease can lead to tooth loss. So just breaking it down and sharing with them why it's so important. Even though 90% of the population has type 2, 90% of the people that are diabetic have type 2. It's great news because it is completely preventable and in some cases reversible. You also want to tell them about the A1C. And so your patient may say, well, why does my dentist care? Again, we're going to share with them why. The studies that show it's an ideal place. Now, we're not checking for the A1C here in our practice, but you're going to refer them to make sure we know what their risk level is, right? Go back into the difference between an A1C, which is 2 to 3 months, looking at your blood sugar, versus fasting. So you want to have that conversation. How do we make an impact? One community at a time. And when I say community where we work, going back to social determinants of health, where we work, live, eat, and play. So I'm sharing this message with you, not only as a provider, but also as a family member. Go back to your family, your immediate family, and have this conversation. Hey, we've been talking about these things. We've been talking about diabetes. When's the last time you had XYZ tests? So let's focus on it one community at a time. prevention and wellness. So the days of us doing just strictly drill and bill, we still have to take care of that, but we want to educate our patients. We want to focus on prevention and wellness. Let's figure out how we can encourage them to become healthier, right? So as we mentioned earlier, some things that may affect it is the genetics, the oral microbiome, socioeconomic status, oral health literacy. So important that we really look at that. Some of our brochures are just full of information and sometimes too much. And what happens is, as we saw in the video with the touch of sugar, the one patient said, my doctor said I was diabetic and gave me a pamphlet and that was it. That's not good enough. Pamphlets sometimes can be confusing. They sometimes have way too much written verbiage versus pictures, but we want to make sure we explain that to them. Community-based oral health intervention programs, Project Head Start, Community Health Department, FQHCs, those are federally qualified health centers. That's an excellent place to share this message. Focus on those at risk to share it. Going back over what we've mentioned before, the weight, the ethnicity, if you've had diabetes before, all those things. And certain ethnic groups are more at risk. African American, Alaskan Native, Pacific Islanders, Hispanic Latino, American Indian, Asian American. So again, having the conversation. Community collaboration. As I mentioned to you before, it's my dream that we start speaking this language and our other healthcare providers start speaking the language in assisted care situations, in urgent care centers, residents for seniors, community centers. We've got to get this word out about being checked for diabetes. I don't know if they're able to do that at the assisted living centers where you can actually do finger pricks. I would imagine they have a glucometer on site because you're going to have patients that are diabetic, but everyone's speaking that language, especially in our healthcare communities, about when's the last time you went to the dentist. Interprofessional communication. Have you thought about having any kind of lunch and learn? So, we get people come to our office all the time. Hey, doc, can we have a lunch and learn so I can show you the latest on the whatever technology it is, right? Maybe I'm inspiring you or encouraging you to think about having a lunch and learn. It can be over Zoom with people that you're in close contact with. If you have friends that are in these categories, nurses, nurse practitioners, osteopaths, any type of healthcare arena, perhaps consider having this conversation with them so that we can get the word out, okay? Home health aides, especially caregivers and home health aides, because they are around our loved ones. They get to see they're changing their clothes, or they're sometimes cleaning, right? Washing them. They can examine their feet. They can see things that we may not see. So again, letting people know how we can get this out. Interprofessional education. This was an opportunity at Pacific Tigoni that we had a few years ago where we worked with the UCSF medical students. And so that's something else we want to do. We want to partner with our other allied health and our other professions, medicine, podiatry, pharmacy, etc., where we can come together and bridge that gap. Lifestyle changes. This is that big buzzword. I think we've all heard that. When you find out your blood pressure is starting to go up, or you're gaining a little weight, or whatever it is, what's the first thing your primary care says? Lifestyle changes. So once you have diabetes or pre-diabetes, your priorities should change to focus on your health, right? I think we as healthcare providers, unfortunately, sometimes can be the worst ones. We're so busy taking care of everyone else that sometimes we forget that we need to take care of ourselves. Self-care is huge, because until we do that, we can't continue to pour into those that we really want to help with their oral health. What are some of the obstacles for achieving ideal oral health? The things we just talked about: health literacy, socioeconomic factors, and in the public health world, something called the health belief model. I'm going to see, where are we on time? Hang on one second. Okay, we're good. Let me go back to presentation mode. So I am going to play this short video for you on what the health belief model means.
The health belief model. In this video, we are going to show you an example of someone using the health belief model to adopt healthy behaviors using the 6 important steps of the health belief model.
This is Jeff. Jeff recently was informed by his doctor that he is in the overweight category for his BMI. Jeff is now aware and concerned of his unhealthy lifestyle.
Perceived susceptibility. Jeff believes if he keeps up his eating habits and his lack of exercise, he could become obese.
Perceived severity. Jeff believes the consequences of becoming obese could lead to other health problems and that this could be a serious enough condition to try and avoid.
Perceived benefits. Jeff thinks that having a proper diet and exercise will prevent him from becoming obese.
Perceived barriers. Jeff is embarrassed to go to the gym because of his lack of knowledge about exercise, so he seeks a trainer.
Cues to action. Jeff leaves a sticky note in his mirror to remind him to work out every morning and rewards himself on the weekends for having a well diet during the week.
Self-efficacy. Over time, Jeff builds confidence exercising and eating right, which allows him to keep on the positive behavior.
All right.
The health belief model.
Got a second. We got the next one. So what we just saw in that video, right? In other words, what's going to motivate people to modify their behavior? So this is what the health belief model is all about. Is it either about the susceptibility, the severity, the benefits, the barriers, the cue to action, and then self-efficacy? So in that example, perceived susceptibility. What happens when I don't follow the recommendations? What's going to happen, right? Am I susceptible to more cavities? Am I susceptible to greater gum disease, periodontal disease? Perceived severity. Can the consequences of me ignoring this condition lead to worse outcomes? Kind of the same thing, right? Perceived benefits. Well, what's in it for me? Why should I do this? Why should I floss? Will it make things better? And what are some of the barriers? What's keeping me from making changes to improve my health? Oh, I'm too busy. Oh, I'm too tired. Oh, I don't have any money to buy floss. And what's the cue to action? This one kind of made me giggle when he showed him writing a sticky note. I have had patients share with me, that's how they remember to floss. They literally will write a sticky note and put it on the mirror to help remind them. So whatever it takes to help you, our patients and ourselves to carry out that positive action. And then the self-efficacy, build habits to enhance the positive behavior. Once you see the results, I've had patients that came back once they embraced the flossing techniques that we show them and really worked on it. And then they come back and they're excited because their gums don't bleed anymore. They don't hurt and they feel better. So that's what the health belief model is about. It's not enough just to tell our patients to brush and floss. We want to say things and arm them with information to help them hopefully modify their behavior. And a few last things I want to talk to you about is something called Community Dental Health Coordinator. You may have heard about this from the ADA. And what they do, they're like community health workers, but they're trained within their communities to help build that bridge between oral health and the communities. Their role, it was piloted back in 2006 by the American Dental Association to provide care coordination, provide community-based prevention, right? Provide oral health education. So typically they're dental hygienists or dental assistants and other people in the dental field that will be that liaison, right? Or the connector between dental care and the patient. What we talked about before, a lot of people have not gone to the dentist. We saw that the reason 40% of adults have tooth decay, and more than 80% don't go receive health care because they don't know where to go, et cetera. So community dental health care workers focus on dentistry, whereas community workers focus on overall health. And I think our time is getting limited, so I'm going to skip this video. Oh, hold on. Let me see if it's going to let me move. There we go. Prevention matters individually and community. So remember, we are all part of the community, not only in our offices, but where we live, and hopefully wherever we might be volunteering. The role of the community health workers, they can work in the this Head Start programs. It can work in the clinics and schools and private practices, collecting information to help address those social determinants of health we talked about, the health literacy issue. It really makes a difference when you have someone that can just break it down for you. And again, sometimes that's a language barrier. Here are some programs by the CDC, National Diabetes Education Program. You can go online and find this information. They actually have resources within your communities. Partnering with the National Diabetes Education Program. This is another example of when you go to the CDC website and you click on this, they will actually have resources broken down for different ethnic and racial groups. And that's critical because again, that's when it comes back to health literacy, correct? Working in culturally diverse communities. National Diabetes Prevention Program. And this is the most recent update from our current Surgeon General, Dr. Jerome Adams. So let me play that for you regarding oral health.
Hello, and thank you for joining us today to learn about the development of a new Surgeon General's report on oral health. It's been nearly 20 years since then U.S. Surgeon General Dr. David Satcher issued the first report on oral health in America. The goal of that first report was to define, describe, and evaluate the interaction between oral health and health and well-being throughout the lifespan and in the context of changes in society. That first report, which called for a national effort to improve oral health among all Americans, certainly did that. It also drew much needed attention to the importance of oral health and sparked additional investments in oral health programs by the public and private sectors. Since that time, oral health has certainly improved for many Americans. Our public and private partners have been working diligently to overcome the challenges described in the 2000 report. Whether it's to undertake scientific research to advance our understanding of dental, oral, and craniofacial diseases, to create and test new ways to improve access to dental care, or to develop innovative ways to bring preventive oral health services to people of all ages. But unfortunately, not all groups have benefited equally. We continue to see vulnerable populations in this country affected disproportionately by dental disease. I believe that as a nation, we can and we must do better. Improving oral health is a personal passion of mine. Ever since I worked as an anesthesiologist in a county hospital and saw the effects of severe oral disease, conditions that could have been prevented, but because they weren't, individuals underwent unnecessary surgical treatment. The new Surgeon General's report will address critical issues and persistent challenges, as well as new and emerging opportunities. My charge for the group working to develop the new report is as follows: to describe and evaluate oral health and the interaction between oral health and general health throughout the lifespan, considering advances in science, healthcare integration, and social influences to articulate new directions for improving oral health and oral health equity across communities. I view this effort as one of the most important during my tenure as Surgeon General. I encourage you all to work with me to lift up oral health. Help make the case to your communities of the importance of oral health to individual and community well-being and quality of life.
To learn more, visit surgeongeneral.gov.
So this was released in 2019. So it's good to know that
Produced
our
by
current
the U.S.
Surgeon
Department
General
of Health and
is still on board, realizing, again, the importance of oral health. See if I can get out of this slide. There we go. How do I talk to my patients? These are just some sample scripts, some of the things that we've actually used with our students, because we do diabetes risk assessment in the clinics. Ultimately, communication is the key. You see, I say practice your scripts and make them your own. But whatever it is that you want to say to your patients, right? Here's some examples. Can diabetes ruin my teeth? Why are you asking me about it? sometimes you get patients that are like, well, you're not a doctor. Every now and again, you get those. So again, our goal is to educate. Those are the things that we want to do. Whose life will you impact today? I encourage you to start with yourself. Take the diabetes risk online test. Contact your primary care and request an HbA1c if you have not had one. And I want to thank you very much. I hope this was informative for you. And if you have any comments or questions that you'd like to address, I am definitely looking forward to interacting with you. So I'm going to stop sharing my screen. That's my contact information. I am at Pacific Dakota on Mondays. I'm in private practice Tuesday through Fridays. I'd love to collaborate with you. If anyone here wants to look together to maybe come together for some health fairs that are in your neighborhood, maybe we can put our heads together as an organization and support that. So I'm going to stop share right now. And that's what I have for you.
All right. Well, thank you so much, Dr. Benton, for the very informative presentation. I think now I probably want to get my A1C checked. Let's see. Yes. So I guess now I'm going to read a few questions that were sent in. And for those of you that are participants in this presentation, feel free to send in some questions right now. And then if we don't have time to get to them, we can always email the answers later. So I guess some of the questions that were sent in, this first one, what are some of the steps dentists can take today to help improve patient care in their office for those who are diabetic? Very kind of general question, I guess. So.
Sure. Definitely, I would say well, first find out, their status, right? So if patients disclose they're diabetic, having the patient understand, knowing what their blood sugars are on a daily basis is so important. That's the first thing. And then explaining to them how the connection with their blood sugars fluctuating impacts their risk of periodontal disease. Of course, we always say gum disease to them. Taking the time to do that, but really helping them understand so that they can take ownership is really important. Stressing the importance of flossing. I will say to my diabetic patients, we're all excited if you floss once a day, but I will say it's really important that you make it at least twice. See, I grew up where you're supposed to floss after every meal, but we know people have very crazy schedules. So I definitely encourage their hygiene to make sure that they take that to the next step.
Right. I think one thing I also like to use personally myself is that, I tell patients that, you don't have to floss all your teeth, just the ones you want to keep.
Yes.
I think lots of people have heard that.
Yeah,
so.
Exactly. I love that one.
Let's see. I think we have another question here. Are there any recommendations for treatment modifications for patients with type 1 versus patients with type 2 diabetes?
So most of the literature is showing the improvement with type 2. And I'm not sure why. I'm guessing that's because, of course, we're talking about insulin resistance, right? So if we are controlling the pathogens, the treatment in terms of periodontal disease and scaling and root planing, all of that would not change. That's going to be the same. The effect that it has on their blood sugar, most of the studies are talking about type 2. And again, I'm not quite sure why, but we definitely would want to explain that to our patients, seeing them more frequently. So once we've done the scaling and root planing, making sure they're coming in every 3 months, absolutely. Some of your SRP patients, you may do 4, but you want to keep them on a closer regimen. So at least every 3 months, and just again, encouraging them about their home care.
Excellent. Cool. I'm just kind of checking if there's any more questions that were sent in. Let's see. So I think that's all for today. I mean, just any last takers from the participants here. Let's see. And if not, you could always email us with any additional questions. So I guess, thank you for joining. Oh, yes. Oh, we got a thanks for the wonderful lecture. We got 2 from, we got 2 thank yous here.
My pleasure. I hope I shed some pearls and encourage everybody to consider implementing a diabetes risk assessment program in your practice. It'll literally your back office can do it. You know, while you're getting ready, going to the next patient, they go to that website, ask those 7 questions, and then just share that information.
Oh, yes, yes, of course. I really want to know my A1C. Hopefully it's below 5.7. You know, I'm just really curious now.
Right.
Scared at the same time.
The good news is once you find out, then you know what you need to do, right?
Exactly. Let's see. All right, everyone. Thank you for joining us, and we hope that you found the information helpful. This meeting was recorded and will be emailed and posted on our SMCDS Facebook page. Stay safe and enjoy the rest of your weekend. Thank you so much, Dr. Benton.
Thank you so much. My pleasure.
All right. Good night, everyone.
Bye.